Hey everybody, this is Kevin and Zain from RPH Ally and the Healthcare Tech Channel. We're on the Healthcare Tech Show, and today we're talking about something near and dear to Zain and I's heart. I know that adherence is probably a burden for you guys as well. Sometimes it's a question of why can't folks just do what they need to do to take care of themselves? And you know what? Zain and I are going to jump into that a little bit to kind of unravel a few things and some of the frustrations we've encountered in our careers. We'll talk right after the reel. So it was so interesting, Zain. And by the way, it's so good to see you. I love the Chicago Bulls cap you've got on there. They used to beat the Utah Jazz all the time, which is the team I used to root for. And man, Jordan just smoked them.
I'm sorry. I'm sorry that you were a Utah Jazz fan. I mean, you had Seattle, man. Why
Well,
didn't you?
I did, but then after Seattle went and Jordan beat them, then I had to root for everybody else that Jordan went up against. So, oh man, I lost every time. But with that all being said, losing every time, adherence can feel like a losing battle. And I feel like you bringing the conversation up was interesting, knowing your oncology background, because typically when I think of who does fairly well with adherence, a lot of times cancer patients are known to be more adherent, I guess, overall. But I'd love to hear some of your insights and what you've kind of seen throughout your career with adherence struggling inside and outside of that oncology space.
Yeah, no, I think that adherence. Okay, so adherence is an issue in general. And I think it's an issue because I think we try to make it like a black and white issue, and it's really not a black and white issue. And I think the reason why maybe in oncology the adherence is so high because the patients are very cognizant of the fact that they're taking this medication for their disease, right?
Yep.
I'm sure you can speak to this, but I remember talking to a patient when I was a resident. She was on blood thinners for she for like yeah, it was a pulmonary embolism actually.
Okay.
So she was put on blood thinners and she came back for clots in her legs. And I'm going through the medication review. I have to go interview the patient and the nurses and the doctors. And so I first time I went in, I'm like, hey, are you taking these medications? And she's like, no, I'm not taking this medication. I'm like, oh, why aren't you taking I can't remember the medication itself. I'm like, why aren't you taking this medication? She's like, oh, I don't really need it. I'm like, oh, no, I think you need it. I mean, you came in for a blood clot. This is supposed to prevent the blood clots. And, it's like, oh, really? I didn't know that. And so right thing right there, adherence. What helps with adherence is not knowing, right? So what ended up happening is she kept refusing the medication throughout her thing, and eventually the doctor had spoke to her, I'd spoke to her, nursing staff had spoke to her. I went in there again one time, and then I was walking in, and the nurse was like, hey Zane, do you mind like talking to her again about this blood thinner? And I was like, yeah, sure. I mean, I don't know what I can do, but I'll try. And I kind of sat there. I was with her and her family for like 10, 15 minutes telling her why she needs the blood thinner. And I got pretty in, like, I was like, hey, you could possibly die if you don't keep taking this.
Yeah.
And I told her what she's taking it for and what the ramifications are for not taking it, right? But when you're dealing with oncology, you don't have to tell that to anyone, right? Because usually when somebody hears cancer, they're like, holy crap, like I might die from this, right? So so that's one thing. I think another thing is just the education piece of it. I think we throw so much at patients all at once.
Yep.
And I think this is where technology can come in really handy, is when we can like trickle the information over time, right? Like, they come see us, we tell them, we go through our spiel, right? And then we just keep reminding them the information over and over, not over and over again, but maybe like sending them bite-sized pieces of the information. Like, for example, a great example is antibiotics, right? You as a pharmacist, we all know it doesn't matter if you feel good, you have to take the antibiotic the full course. I don't care if you feel good at day 3, you finish the 7-day course, right? I mean, how many people in our own families stop taking it, right? So, like that instance, like, hey, we tell them all this when they take it, and then maybe on the 3rd day they get a message, be like, hey, how are you feeling? Are you feeling good or no? Even if you are feeling good, please continue taking the medication, right? Just like a simple reminder like that, I think would help with adherence.
Wow. Yeah, I think you bring up so many good points. The one thing that I'll do is rewind us just slightly on like what is adherence? Like when we hear, at least in my mind, like compliance means, are you doing what I told you to do? Adherence is, are you doing what you're supposed to be doing? And so Like those two pieces really bring in like patient behavior. Like, is the patient behaving the right way? And one term that I've heard thrown out there is concordance more recently. And that's really along the same vein as what you and I have seen both in the technology world and just the general healthcare space of seeing more and more shared decision making processes inside of the healthcare journey. I think that fits in the a couple different models, but one is probably motivational interviewing model for individuals to assess what their own motivations are for doing a thing. If that is physical therapy, like why am I going to physical therapy? If that is breathing treatments, if that's taking a medication, if that's eating differently, if that's exercising, whatever it may be. And so those things I think are really interesting on just how we phrase something, just the psychology behind the wording can really add a level and a layer of responsibility to, whose fault is it when we don't see it being adhered to. Um, but then going a little bit further, like you were saying about an oncology patient, just really to get it, like it is a very serious issue that they feel like they can treat something immediately. Oftentimes when we look at adherence statistics, Zane, that you and I are seeing, like in antibiotics is another good example because it's a microcosm of the macro. It's about chronic care, right? So if we have something that's very acute, very serious, very insipidous, like going on, or insidious going on, versus something that is you just got high blood pressure or you just got diagnosed with high cholesterol, them seeing the tangible results of taking those medications is just more difficult overall. So there's that interesting level of disconnect. What have you done or seen, Zane, in the adherence space or concordance space when it comes to connecting the dots with something that isn't, like the individual that had a blood clot, because there you've really got to move them down the motivational interviewing tract and help them see the very grave consequences of this in a short period of time. Does that differ for you when you're working with somebody and you're telling them this is why you've got to take your, blood pressure medication?
I don't think so. I think that I think the reason we fail, I shouldn't, let's just actually, yeah, the reason why we fail is I think we take things for granted. Like, we always tell our patients, oh, you're taking it for granted. Like, I was talking to somebody the other day, and, we were talking about quote unquote lifestyle diseases like diabetes and hypertension. All these have become quote basically lifestyle diseases, right? Thankfully, we've come far enough. But what's happening is, like, are you really living a comfortable life being a diabetic or hypertensive or things like that, right? Like we've gone into this thing where we've taken the power away from the patients to help themselves, if that makes sense.
It
And I
does.
think that there's no ownership of your own health anymore. Um, and like, we've created a system, and it's hundreds of years old, where we expect our patients to come to us and they're looking for a solution, and we just give them the solution, right? That's just it's a transaction of some sort. I think what we need to do is empower patients to take care of their own health, because once you have ownership of your health, then you're going to be more cognizant of it, right? Like, we should just be the shepherds of their hopefully healthy lifestyle. And I think that's one way to do it. But when I approach things, like when I always talk to patients, I don't take it for granted. I don't care if it's like a antibiotic, it could be a gout medication, whatever. Like, I try to make sure that they know exactly why they're taking it, what they're taking it for, and what might be some of the consequences if they don't take it, right? And
Mhm.
then also, we have to celebrate the small victories of our patients. We, anytime you talk to somebody who's worked in medicine, it's always a trend, right? We don't look at the individual marker, like individual day, that moment in time, because it can be high, low around that time. We're constantly looking at trends in the inpatient world. So why don't we give our patients the same leverage of a trend? As long as they're trending in the right direction, they might not have hit their A1C goal, but hey, they dropped down 0.2%, zero point 0.2. That's still something to celebrate. And I think that's another thing too. Like, we don't we're not celebrating the small victories with our patients. And I think that if we did, and like, no one's perfect. So I think we need to, like, again, going back to like shepherding them through it. We know that you should be here. They probably know they need to be here. They're scared to see us because they know they've been bad. Kind of like the dentist thing, right? We're not, no one flosses until like the day before the day of the dental appointment. We all know, the dentist knows we haven't flossed for the last, 6 months, but we still do it, right? It's the same thing with your health. And they're afraid. Just come see us. So why, let's not make it something where they're scared to see us. Let's open the channel, let them take control of their thing, and we should just be there to help them.
Yeah, you hit on several things that I think are really holding us back that we can now tie into 10 minutes in, guys. This is the healthcare tech show, and we will talk about tech next. But you tied in some things in like paternalism and ownership, right, of an individual disease state. And you also talked about before, like reminding, like that education that you say that you take an individual and make sure they understand why they're taking something. That one interaction is great. I know that I can tell Zain one thing, he'll memorize it, take it to a whole nother level, and then be able to replicate it for the rest of his life.
Yeah.
I'm not like that, right? And so I think that's one reason why my wife has to repeat things, right? I'm sorry, Smith. But that kind of help that we can use through technology, that we have that resource we can go back to and be able to leverage for our patients in the outpatient world. And even in the inpatient setting, where we're leveraging technology to be able to remind us that, hey, this individual drug should be dripped at this rate. And remember that it can cause phlebitis if we do it differently. And here's the way that we should mix it, et cetera. Like all of those little reminders, after you've done it 1,000 times, can still be helpful, to you to be able to see, oh yeah, that's right. I gotta do this because I'm thinking about 100 other things. Well, guess what? Your patients are too, right? So having those little reminders, I think, is a huge one, Zain. The other one you talked about is the empowerment. And I think that you and I are both big on, I was just talking to Thea this morning about RPM or CCM, like types of things. And I really think the one interesting thing of trend tracking is the ability for patients to track their own trends, for them to see that exact same chart that's always being faced in this direction so that you're just looking at it and they feel like they're being judged. Now they see exactly what's going on, and can see, hey, this is where I've been trending. It's not just about this one spike or this one dip. It's about the direction that we're going overall, and this is how it's improving my overall care. So I think there's those elements to be able to bring to patients that are of huge positive kind of benefit. And then, two, the personalization like kind of pieces. So you just went to a conference and talking about pharmacogenomics, pharmacogenomics and seeing patients that say, I believe more in my therapy now because I see the individualized elements related to how drugs are metabolized by my body, right? And so I think all of these technologies now allow the patients to feel more connection with their treatments and feel like there's more value overall from my perspective. But those are a few of the like technology, just tiny little things that technology is offering us today. Any other stuff, Zane, that you've seen, you've been excited about to see technology help in the adherence concordant space?
I mean, there are some. I mean, I think that we like the things that I'm really excited about is kind of like that drip education. There are companies that are kind of talking about that, like taking the patient through the journey, like whether it be pre-surgery, post-surgery. That's a great example, right? You could be very healthy, you tear your ACL or whatever it happens to be, and you're now on multiple medications and multiple different treatment things that you never started, right? So you leave with a binder that's 3 inch thick. No one's going to read that, and it sort of helps that way. I think the RPM space, remote patient monitoring, or just personal monitoring is also another thing. Like I think psychologically, if you see yourself getting better, because I don't think people realize it's just small little things that can really make a big difference over time. And I think patients don't see that until they see us like once a year, twice a year, right? Like there's going to be peaks and valleys. So I think that's another thing. Again, taking ownership of their thing. But I mean, I think another thing is that I think it's missed quite a bit is adherence in like non-English speaking,
Huge
uh, um, or
populations.
populace. Thank you. English is my second language, guys. So yeah, but yeah, that's where like I'm really excited for things like NLP and things like that, where we can, or AI. Like this is where I think AI can make a huge difference in adherence. Is translating some of our material in different languages to where they can understand it. Taking a doctor's note or an after visit summary and dropping the grade level to like a third or second or fourth grade reading level. So when we do hand them the sheet, they're not just looking at us like, yeah, yeah. And then, they're scared, crapless.
Mhm.
And I think those are areas where technology, they seem like really small things, but they can make a massive difference.
Oh, I mean, I it's so funny how we like to complicate things so far that we get past it is a really powerful tool, a calendar put on someone's fridge that says when they're taking their drugs, right? I mean, just super simple things that help just remind people about, oh yeah, this is when I take them. These are the little things I'm supposed to look out for. All those things on a crayon created, little sheet can be vastly impactful. And so I think that even though the technology is going to take it to a whole nother level of connection and understanding and bring it back to the healthcare world to be able to prioritize which patients we need to touch on first, what things are we doing that's going to be the most impactful with changing the trends in care. I think those really simple things, those little iterations that we can make inside of the overall care model can be pretty massive. When it comes to change that you've seen, Zane, like any patient stories or any other like examples, you'd be like, hey, Kevin, this is something I did. This is the way it impacted the patient's adherence in a positive way.
Yeah, I mean, being in the oncology, so there was that one lady there. There was another. Actually, it was just actually during my time when I was a student in fourth year. So I was at the VA, and the preceptor had an amazing job where she had her own schedule, and she worked in a clinic where the providers would send her, quote unquote, the difficult patients, right, like hypertension, diabetes, COPD, like chronic diseases. There was this one lady that was a paraplegic, lost both of her legs, and she did not. She and she lost him because she lost him because of diabetes, not because of what you know during like going out to service, and she was never adherent to it. She was like she had blood pressure, diabetes, all that stuff. And my teacher one day was like, "Hey, are you guys okay with seeing her by herself?" And I was like sitting there like, she was like, "Oh, this patient she's really nice, but she can be a little difficult, whatever." I was like, "Okay, fine, let's see." So the first interview, I talked to her. I'm like, "Hey, are you taking this?" She's like, "No." "Are you taking this?" She's like, "No." "Are you taking this?" "Oh, yeah, I am, but I'm taking like half the dose." I'm like, "Okay, cool." I put all that down, and then I kind of was like, "Okay, something else is going on here." So I was like, can you tell me why you're not taking it? Like, what's the reasoning behind it? I mean, to me, it doesn't really matter. I'm just a student here. Like, I'm no judgment. I'm just trying to understand why you're not taking it. Is it side effects? Is it that you can't afford it? What is it? Like, why aren't you taking it? So came to a point where she was really proud of the little steps that she was making on her own. She didn't want to rely on medications. She didn't want to do all that stuff. So that was her motivation for not taking it. She didn't want to take it because she was trying to like screw the man or screw us. She was trying to get healthy, but she was trying to get healthy off of the medications. So after I found that out, I was like, so I had kind of like a pseudo heart to heart, like kind of also telling her that this is not good. But like, I tried to be like civil about it, be like, hey, I completely understand what you're trying to do. I commend it actually. But what we need to do is your numbers are so off whack. So I told her, like, hey, even if we can get your numbers down to a certain point. Why don't you take these medications, get your numbers down to a certain point, and then maybe we can start weaning you off of these medications, right? And this was a conversation no one had with her. And she's like, okay. And then we kind of talked for like 15, 20 minutes. So next time she comes back, she didn't take all of her medications. And I saw her again, right? But she was taking more of her medications and her numbers were getting better. And I was like, instead of like getting mad at her, I was like, yes, this is awesome. Do you see what taking some of your medications is doing? We are getting close to the goal. And, that next interview I knew she wasn't taking them. It wasn't me like chastising her. It was just me like supporting her and cheering her on. Be like, yes, we can do this. We can get going. And she left way happier the second time the first time, but she did say like, hey, I'll try to take your medications. And then after that interaction, like the second time she came, my teacher came to me, not teacher, my preceptor. Well, she actually was my teacher, but she came to me and she's like, hey, what did you guys talk about? Like, what made her take what did you do? And I just told her, and she's like, oh, that's great. But like going back to like just healthcare is a human thing. It's not just people aren't being non-adherent because they want to live a less healthy lifestyle. No one wants to live a less healthy lifestyle. But you just need to get to the root of why they're choosing to do the things that they're choosing to do. And it's up to us, because we have the domain knowledge, to help them guide guide them in different ways. Maybe we need to find something that works better for them. It might not be exactly what it is, but sometimes something says 4 times a day, they can't take it 4 times a day. You're like, okay, at least take it 3 times a day. Just take it twice a day. Like, let's start with twice a day, and then we keep moving forward.
Yeah, I think that demanding anything is difficult, but demanding perfection is just it's unreasonable, and I think that's what a lot of folks need is they need some grace and they need some love, people to look at them like you did, Zane, with her, to ask her point blank, what's the reason behind it? I'm not judging you. What's the reason behind it? Get to that core kind of reason and rationale, and then be able to help them to recognize that sometimes there are win-wins that are possible. There are scenarios where they can still feel like they have control, they have the ability to do what they want to do, and you can show them a slightly different path than they thought was just black or white, with the next steps they can take in their kind of adherence battle. But I do think I think last story is one that Bruce Berger has told me several times. And he said he had a patient that, has an example as a patient. You have a patient that comes in, hasn't taken their lisinopril only 2 days during the previous week. And so, a couple options are, one, you could go in there and you could tell them, sir, why have you not taken your lisinopril, these 5 days of the week? Like, that it's important for your blood pressure. It could cause heart attack and stroke and yada, 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 and really get on them. And then you can tell them who, what they need to do, and they can go off and they can say, yes, 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 and then do the exact same thing. The alternative that he suggests, which I absolutely loved, is go in there and ask them, why did you take it those 2 days? Like, what was your motivation for doing it? Like, you did it for those 2 days. You picked up that drug from the pharmacy. You have in your possession. I had a patient one time, Zane, that he would take an inhaler. It was a long-acting inhaler, and he would take it and document when he took it and write voodoo next to it every single time. I think I told you that story once. But anyway, I just thought that is so awesome that he cares enough to take it. His COPD was progressing dramatically. And so the beauty of that was just, one, congratulating him for taking it, being there and being present and kind of connecting the dots with him on, like, I appreciate that you're taking it, and having a real human connection. And I feel like that's the beauty of the technology piece that we can tie in. We can see the trends, we can track the pieces together, and together we can look at those pieces of information and make adjustments. And I think there's our shift from adherence needs to become concordance, for us to be able to move forward.
Yeah, and I think that highlights exactly what I think health tech should be. It should be a tool that helps us connect with each other more on a human level. It's not something that'll replace us or take, it's just something that helps us connect with our patients better so that we can help them, because that's really what we're trying to do. We're just trying to help them. And the more information, I shouldn't say the more information, but like the more good information we have about them, the better off we are.
Perfectly said. Yep. The more they feel like we actually care about them, and the more information that we can share and exchange together to be able to collaborate on it, we can actually move the needle, so to speak. Even though maybe I should stop saying that move the needle term, but now I'll keep it. All right, buddy.
It could be a thing.
It could be my thing. There you go.
Kevin, move the needle walker.
Hashtag move the needle. Well, everybody, thanks so much for joining us. We'll talk to you again here hopefully soon. Head over to RPH Ally, join the Healthcare Tech Show. One thing that Zane and I, we probably should have announced at the beginning of the show, we're going to do it now, is we'd like to start doing something at the end of the month, like at least once a month, of having a little bit larger conversation where we bring a couple people in to be able to talk about a larger topic kind of in healthcare. And so we'll be starting those up soon. If you have any ideas for us, or you have any suggestions for the show and other topics you'd like Zane and I to cover, then let us know. We're both working in the health technology world as project managers or as advisors. And so we always are interested in hearing what your guys' thoughts are and what your perspectives are inside of the health tech space.
Yeah, no, and if you want to join us, you personally, please let us know.
Love it. We'll bring him behind the stage, and I promise I'll only say move the needle like 3 or 4 times with you. All right, guys, take care. Bye-bye.